Hello, everyone. My name is Heather. I'm the Medication Safety Forum Chair for FSHP, and you are in for a real treat tonight for this webinar. It's called The Road Less Traveled When Medication Takes the Wrong Route, and we have three wonderful pharmacists here to present this tonight. We have Michelle Lamarque, who is currently the Medication Safety and Quality Coordinator at Homestead Hospital at Baptist Health South Florida in Miami, and she obtained her Doctor of Pharmacy from the University of Florida in Gainesville in 2007 and served on multiple capacities at the hospital level, including oncology pharmacy, pediatrics, and the operating room. In her current role, she's the chair of the Med Safety Committee and is also involved in other multidisciplinary committees, including Clinical Practice Council, Pharmacy and Therapeutics Committee, and the Residency Advisory Committee. She's been in her role for 3 years and is an active member of the Med Safety Clinical Forum for FSHP, including participation in the quarterly newsletter. So we love Michelle. We also have Dr. Shivana Syne, who is currently the corporate pharmacy director at Med Safety and Quality for Baptist Health South Florida Enterprise in Miami, Florida. Dr. Syne obtained her Doctor of Pharmacy from Nova Southeastern University in Fort Lauderdale, Florida, and her passion for pharmacy practice and leadership led her to serve in multiple leadership roles at the hospital level and roles at the system level, overseeing multiple hospitals. And in her current role, she's directly overseeing the med safety, pharmacy operations, and regulatory program for the enterprise hospitals. She also serves on several state and national pharmacy organization committees. And then we also have Dr. Sonia Leon. She received her Doctor of Pharmacy degree from University of Florida in 2007. Following graduation, she completed her ASHP accredited PGY1 pharmacy residency with an emphasis in pediatrics at Baptist Hospital of Miami. She's also worked in various settings, including the neonatal ICU and emergency medicine, and she's been the Med Safety Quality Coordinator for the past 5.5 years at Baptist South Miami Hospital, where she serves as the chair for the Med Safety Committee and as a member of the BHSF Medication Safety Corporate Committee. She also serves as a patient safety champion and participates as a member in the Patient Safety Committee, Clinical Practice Council, Performance Improvement Steering Council, Clinical Peer Review Committee, Pharmacy and Therapeutics, and also Residency Advisory Committees. She's a busy lady. Dr. Leon is a clinical preceptor for Nova Southeastern University College of Pharmacy and completed the ASHP Med Safety Certificate and is also a Lean Six Sigma Green Belt. Her current practice includes working collaboratively with health system leaders, prescribers, and clinical staff to define, design, improve, and educate on the safe medication use processes while upholding a safe culture. So I will turn it over to these lovely pharmacists.
Thank you so much, Heather,
Thank
and good
you.
evening, everyone. Thank you for joining us today for this webinar. We're going to jump right into our objectives. So today we are going to talk a little bit about the general statistics about medication errors and their occurrences in published data that's out there, but the organizations that review these errors. We'll also talk about a few different examples of errors that are related to medications that are being given through the wrong route, but we will dive in a little more specifically, talk about tranexamic acid, as well as some oxytocin, epidural infusion-related errors. And we will look at what impact these types of errors have on patient care and patient safety in general, and also review some of the prevention strategies that could be put in place to proactively safeguard against these types of errors. So when we look at the data that's out there right now, according to the FDA, Food and Drug Administration, they receive approximately 100,000 or more reports every year that are related to medication errors. These are all medication errors. And in the US, in the United States, about 7,000 to 9,000 of these errors lead to deaths almost every year. So medication errors are generally considered preventable. So these deaths mostly are preventable deaths. And so that is a high number that results in these types of events. In terms of wrong route errors in particular, it is estimated that if we look at all patient settings, inpatient and outpatient, These errors, specifically wrong route, account for about 20% of errors that occur related to medication. And in another review, which looked at 91 observation studies, this looked more specifically at inpatient, both long-term care facilities and hospitals, and the incidence of medication errors during administration of meds specifically accounted for about 8 to 25% of occurrence. So in essence, medications that are being administered about 25% of the time, those medications result in some type of error. In specific to IV medications, it is a little higher, where about 50% of IV medications that are administered actually result in some type of error. This includes timing errors, so meds that are given at the wrong time is included in this number. Also, according to the Institute for Safe Medication Practices, or ISMP, in a 12-month period from July 2023 to June 2024, they received a little over 1,000 medication error reports. And about half of those, almost half of those, were related to events that actually did reach the patient. Many of these sometimes are caught before it gets to the patient, but this is almost half of the errors that did actually reach the patient. When we look at the stages in the medication use process, you can see there's several stages that the medication goes throughout the process of storage in the pharmacy, ordering by providers, dispensing, monitoring, transcribing sometimes, and more specifically, the administration stage is where we're focused on today in our discussion of where medication errors can occur. But these specific wrong route errors occur in the administration phase, but all of the other phases are also areas where medication errors do occur as well. These are some of the examples of errors that have been published in literature by some of the organizations that are out there. Starting from the top, there have been errors that have been published looking at the digoxin that was given intrathecally instead of intravenously. There was also cases of nimodipine oral capsules that were given intravenously, and that was related to the liquid inside the capsules being drawn up into a syringe, and that syringe accidentally was given intravenously instead of orally. Similarly, a verapamil oral solution was given intravenously, again, being put into the wrong type of syringe. And we also have cases of epinephrine being given intravenously instead of IM or sub-Q. And vincristine was the error that actually led to the first ISMP best practice, or ISMP best practice number 1, where vincristine had been given in multiple events intrathecally instead of intravenously, and that's because it was being placed into a syringe, where now the best practice recommends those products being placed into IV bags. And the two that we're going to dive in a little more specific today are the tranexamic acid, which also is a mix-up with being given intrathecally instead of IV, and epidural infusions such as oxytocin and bupivacaine and those other nerve block agents being given IV instead of as an epidural. So there's many contributing factors that could lead to errors in general, and some of those more specific to wrong route errors. Those are related to vials, let's say, that have similar packaging. They look alike. The color of the caps or the labels are very similar. Also, busy work environments, there's a lot going on. Distractions could lead to some of these, such as phone calls or multiple events taking place at the same time. Inadequate safeguards. This is sometimes the safeguards are in place, but they may not be robust enough. Other times there's no safeguards in place. And dispensing devices can also lead to some of these. This could be related to automated devices, but it can also be manual tray devices, for example. And tubing misconnections, this is a common one in terms of the examples that we discussed or we will be discussing, where oral meds potentially may have been given IV or intrathecal and IV mix-ups have occurred. So a knowledge checkpoint question before we move on to the next section. Which of the following can contribute to a wrong route error? And you can feel free to put your answer in the chat. So A is distractions, B, poor storage practices, C, inadequate labeling, D, a lack of barcode scanning, and E, all of the above. Okay. And the answer is all of the above. So now I'll pass it on to Michelle, who will then review more specific details about tranexamic acid.
Thank you so much, Shivana. So as Shivana mentioned earlier, tranexamic acid has been highlighted recently as one of the medications that can lead to adverse events when infused via the wrong route. And it has actually garnered a lot of attention from multiple organizations, including ISMP, as she mentioned, and also the Anesthesia Safety Foundation. So we'll dive into that. I'm sorry. Let me go back to this slide. So as far as what is tranexamic acid, so it's an antifibrinolytic agent that prevents the breakdown of fibrin and promotes clotting. It has a wide spectrum of labeled and off-labeled uses in practice. So you may have seen it in several different instances in your institution and practice. So more commonly, we have perioperative prevention of blood loss and transfusion, intracranial hemorrhage associated with thrombolytic treatment, but you may have seen off-label uses, such as for abnormal uterine bleeding or dental procedures, postpartum hemorrhage, tooth extraction, etc. So usually the commercially available dosage forms, the approved dosage forms, primarily approved by the FDA, are IV solution and oral tablet. So when we look at the risks associated with wrong route, if this is given in the wrong route, so if we're giving it in the neuraxial route, potentially you can have a mortality rate of up to 50%. So you can get seizures, permanent neurological injury, arrhythmias, paraplegia, and in many cases have led to death. So a review conducted in 2019 cited 21 cases of epidural or intrathecal administration between 1960 and 2018, and this is worldwide. As you can see, there are a lot of multiple different surgical settings. So including elective cesarean delivery, orthopedic surgery. So these make up the majority of number of cases. So the other cases include cholecystectomy, prostate surgery, appendectomy, but not as many of those. So I'll dive into past events with orthopedic surgery. So as you can see, many cases have led to death, some with full neurological recovery, but it's a sizable amount, and it's pretty common with orthopedic surgery, just because of the methods that they use for pain control, intrathecal pain control. So this can be mixed up. So these are the cases that are that have been reported in that particular report in 2019 for cesarean section. So that this is another common one. As you can see, the epidural route is commonly confused, or is a common route for medication in C-section. So you can see how this mix-up can occur. So moving on to I wanted to highlight a case study that was highlighted in 2019, I'm sorry, hold on, in that 2019 review. So in this particular case, A 68-year-old woman was undergoing a total knee replacement procedure, and they received tranexamic acid intrathecally instead of the intended bupivacaine and morphine. So what happened was that the surgeon planned to irrigate the knee with tranexamic acid to minimize the blood loss. And instead of administering the bupivacaine and morphine intrathecally, they gave tranexamic acid. So the vials were dispensed from the pharmacy as shown. So the tranexamic acid 1 gram in 10 mLs and bupivacaine 75 milligrams in 30 ml vial. However, they were labeled, although they were labeled, they were dispensed for for the surgical suite staff to prepare them in syringes prior to administration. And as you can see, they have similarly sized, they're similarly sized and they have similar color caps. So in this case, the patient developed seizures and they required intubation, intensive care. Thankfully, the patient recovered, but it was a long recovery. So this raised the alarm. So all of those cases that we just discussed in this particular review were highlighted for ISMP and it caught their attention. And so in May 2019, they had an ISMP alert for dangerous wrong route errors, which led to, in collaboration with ECRI, they highlighted the top 10 medication safety hazards of 2020. Actually, it was number 7 for wrong route intraspinal injection errors with tranexamic acid. The National Alert Network was also sent out an alert along with the FDA. So here are all of the alerts. So you can see it was quite sizable. It's actually quite common and it highlights the prevalence. So it's interesting to note that right after the FDA warning in 2020, there was an event that occurred just 3 weeks after. For it actually, the physician was fined and reprimanded for administration of spinal anesthesia. So the intent was to use for the administration of spinal anesthesia, and it was the tranexamic acid was administered intrathecally with the intent to use the bupivacaine instead. So the FDA, because of this case, the FDA asked the product sponsor, which was Pfizer, to update the label to prominently state IV use only on the label. So Pfizer went ahead and made those changes, but they're still pending generic manufacturer label changes. So we'll go ahead and show you this. So in the package insert, the Pfizer package insert for tranexamic acid actually has a section for risk of medication errors due to incorrect route of administration. And they have a warning to confirm the correct route of administration for tranexamic acid. In addition to that, the FDA did require prominent labeling for IV use only. And as you can see, there's a black background in this label where it states intravenous use only. So after 2020, there were several other alerts, including the WHO, so the World Health Organization in 2022, came out with an alert highlighting the risk of medication errors with tranexamic acid. And more importantly, more recently, as Shivana was stating that vincristine had the #1 or best practice #1 for ISMP. This actually had led to best practice number 20 for 2024-2025 for safeguarding against wrong route errors with tranexamic acid. So here's the best practice. So as during the time of the alerts, all of these alerts, the following medications were packaged with the same blue color caps. So bupivacaine, ropivacaine, and tranexamic acid they all had the same blue color cap. So there were multiple events due to these cap mix-ups. So the FDA did release the warning. They revised the carton for revision of the carton labels. And as stated before, they also included incorrect or required that description on the prescribing information. So the best practice recommendations were here as follows. So most of the recommendations have to do with storage, as Shivana went through the different medication stages. Many of the medications with tranexamic acid errors have to do with storage. So, we'll go through them. So it's important to utilize barcode for BCMA, so barcode assisted medication safety checks prior to the administration of medications in surgical areas. And I'm not sure what the composition of the people on the call are, but I know that in our institution and in several other institutions, it's been very difficult to have to institute BCMA. And I'm sure it is in a majority of institutions. It's sort of like the last frontier for BCMA. It's important to use IV bags of tranexamic acid whenever possible, so you're less likely to result in a vial mix-up. And so now we have pre-mixed tranexamic acid available for purchase, and we can use that whenever we can. Like I said, storage is really important here. So check your A stations. Do not store tranexamic acid in the anesthesia tray. Check to see if how we're storing it, if we're storing the injectable medications in the upright position where all we see is a blue cap, so we're likely to confuse it that way. So conduct a review of the Pyxis machines, look to see what you're storing next to each other, and how likely they are to be mixed up. And also consider labeling vial caps with a label that contains, that states prominently contains tranexamic acid. So so going into the mitigation strategies, as I stated, storage is really important. So whenever possible, avoid upright vial storage, and then also use dedicated bins. Take a look at your ADC layouts, your Pyxis layouts, and then make sure that we're safeguarding against storage near lookalike drugs. As far as prescribing, review your workflows for prescribing the medication, meet with stakeholders that commonly prescribe the medication, so surgeons, your CRNAs, and evaluate your ordering process. So can we order this through an order set? Are we standardizing the protocols? Make sure that we're creating standardized order sentences in the EHR. As far as dispensing goes, try to use pre-mixed bags as shown here whenever possible. So we're reducing the reliance on vials. So reducing that chance for mix-up. Using pharmacy prepared infusions whenever possible, and applying either contains tranexamic acid or for IV use only on the vials. Mitigation strategy for administration would be to limit access and keeping it to strict areas in the OR and perioperative areas. In addition to that, implement BCMA in perioperative settings. I know that's a difficult task to do, and it could be a challenge, but it's important to make sure that we're leveraging technology at every step, right? So not only BCMA there, but also scanning and all the different other steps in the medication use process. So storage, dispensing, administration, whenever possible to scan. And also to require an independent double check and in conjunction with BCMA. So going back to the first case study that I mentioned with the unfortunate 68-year-old woman who had to go through rehab for her total knee replacement. Some of the issues that we found there, now that we've discussed some of the mitigation strategies and the other things that we can do to prevent this, were that the vials in that case were similar in size. In that case, the vials were both packaged with blue tops and they were stored upright. In addition to that, they were stored near the anesthetics in the perioperative area. And in this case, there was no barcode scanning in the operative area. So for a knowledge checkpoint, feel free to put your answers in the chat. Which of the following, as suggested by the ISMP best practice number 20, is not a mitigation strategy for prevention of wrong route tranexamic acid errors? A, utilize barcode assisted medication safety checks. B, store tranexamic acid in the anesthesia tray. C, avoid storing injectable medications in an upright position. Or D, consider labeling vial caps with a label that states contains tranexamic acid. And you are right if you chose B. Thank you, and I will pass it off to Sonia.
Hi, good evening, everyone. Thank you, Michelle. So today I'll be talking to you about some epidural safety tips in the obstetrical setting. As you know, epidural infusions can be safe and effective methods for providing obstetric analgesia. However, they are not to be used without risk. In 2007, the National Patient Safety Agency, through the National Reporting and Learning System, reported 6 incidents where drugs that were intended for epidural space administration were inadvertently administered intravenously. Epidural infusions are very widely considered high alert medications by the ISMP. High alert meaning that it's defined as a drug that is has a heightened risk of causing significant patient harm when they are used in air, and the consequence of the error is clearly more devastating to patients. In 2023, 100% of respondents to an ISMP survey of acute care settings found that every hospital that responded was categorizing as epidural and intrathecal infusions as part of the hospital's high alert medication list, which was a big jump from prior surveys where it was barely 80% having those in the high alert list. To highlight a case study where a 16-year-old female was given an epidural medication with bupivacaine and fentanyl, and it was mixed up with the antibiotic IV penicillin G bag. The RN had inadvertently, she had pulled the epidural bupivacaine and fentanyl bag from the Pyxis using the override function in a rushed environment to have it readily available for anesthesia team when they arrived to the patient room at the bedside. The medication was stored side by side on the counter with the penicillin G, and they were both in 150 ml volumes, and they were both labeled with similar looking pharmacy labels. The RN intended to begin the penicillin G infusion. However, instead of starting the pen G infusion, she had actually grabbed the epidural bag, spiked it, hung it, and started the infusion. Quickly after, the patient developed seizures, cardiovascular collapse, and the baby was emergently delivered. However, the 16-year-old mother, despite resuscitation efforts, did not make it. This set off the alarm, like Michelle said prior, in 2007. After all these events were reported collectively, they started to publish more collectively efforts across the country and also nationwide after several events had been found to cause death with unsuccessful resuscitation efforts. So in 2008, the ISMP published the first edition in their med safety newsletters of the epidural IV route mix-ups, reducing the risk of deadly errors. Followed by 2009, when the Pennsylvania Patient Safety Advisory published a statement for medication errors in labor and delivery and reducing maternal and fetal harm. In 2018, the ISMP published an update to their guidelines and recommendations, citing specific examples of epidural anesthesia and IV antibiotics in labor and delivery units, continuing to cause harm in the OB setting. And then in 2020, the ASHP, in their Standardized for Safety initiative, did publish the first round of standardized concentrations that they recommended for PCA and epidural standard concentrations. When we look at the prescribing stages on how we can really mitigate strategies, the best is to really require the providers, especially the anesthesia providers, to place their own orders unless it's an emergency situation. Always allowing the pharmacist to verify the orders prior, again, unless it's an emergency situation. And it's always recommended to use less cardiotoxic anesthetic agents such as ropivacaine in the event of an inadvertent administration through the IV route. Bupivacaine, which has been used in many studies, is the most cardiotoxic and the most potent of these agents. So the ropivacaine is really favorable. It provides it's very well tolerated. It has good pain management, and it also will be easier to reverse in the event of an error. And whenever is appropriate, it is strongly recommended to standardize to a single epidural agent and concentration on your formulary. When we take a little bit of a deeper dive into the dispensing portion, you want to inform other practitioners about any and all changes. One of the things that we found in the prior case that was provided is that due to a shortage, they had changed to providing the bags in 150 mLs, and they looked very similar, and pharmacy was compounding it. So they weren't buying it commercially available, and they didn't look different enough. So in these recommendations, it's very important that any and all changes, especially during shortages, are well communicated with your labor and delivery and anesthesia teams. If at all possible, differentiating the epidural bag. So buying as simple as buying a bottle of ropivacaine and hanging that versus a bag. So it looks like two completely things hanging at the patient bedside. Also using different size containers, different colored shapes, and changing overwraps of products. And always using commercially available products whenever available is highly recommended. It's also important for pharmacies to consider whether or not they should be dispensing with yellow striped epidural tubing, which is usually available in the nursing units with the anesthesia supplies. It's highly recommended that you label for epidural use only. Yellow seems to be the favored and the nationally standardized color for epidural infusions. Affixing these big, large, prominent, and very distinctive labels has really gone a long way. And also ensuring that it's properly labeled on the front and on the back of the bag, and applying port seals whenever possible with warnings information to remind the end user whenever they're going to open the product that this is an epidural product. Scanning each bag when restocking at the ADC, the automated dispensing cabinet, is highly recommended if your technology is capable of that. I know that for us, we're only allowed to scan the first barcode, not other barcodes at the ADC, but if other automation has that capability, that would be a great route to pursue. This is an example to illustrate how bags can look similarly, even though they have even different volumes. So this is an oxytocin on the right-hand side, which is in 500 mLs of activated ringer, whereas the bupivacaine is on the left-hand side, and it's the epidural bag, and it's a 250 ml bag. They look very similar. They both have white labels. They both have the refrigerate stickers, and they have high visibility stickers attached to the front and the back of the bags. But if you look quickly, they're so bright and neon, they actually can look similar. So some safety strategies that you could implement would be, really color differentiation can go a long way. So even though, you may not be able to buy commercially available products all the time, especially during shortages, having different colors can also assist too, and labeling the front and the back of the bags. So as you see in this example, you have I call it yellow bus yellow, school bus yellow for the epidural, and then having like a Kelly green or, a green that really looks very different from the other products can help identify the bags differently on the IV poles. Other manufacturers and 503B compounding pharmacies have come out with different strategies where they'll label the front of the bag with oxytocin, and as you see it from the other side through the back, it actually, when you look through the bag, it'll have another label on the back side that also informs that it's a high alert and it has the oxytocin. So there's a lot of different strategies about labeling that can really assist and facilitate with differentiating the two products. When we drill down into the administration step, which, as Shivana said, is where most of the errors have occurred, it's really important to consider limiting access. So where are you stocking the epidural infusions? Is it in a dedicated epidural cart, in an automated dispensing cabinet? Who has access to that product? Really exploring security group access and limiting providers to being able to access their own products and not letting them access other products. So for example, having anesthesia practitioners being the only ones that can retrieve the epidural bags from the storage locations would actually go a long way. That would also eliminate the need for, chain of custody or changing products between one healthcare professional and another. Establishing a secure and separate process for drug storage is also very essential to this process. Implementing BCMA, as Michelle mentioned, can be challenging sometimes during bedside procedures and the perioperative setting, but it is highly encouraged. Getting creative with your workflows, partnering with nursing, and collaborating together can also go a long way as far as getting BCMA to do like that second extra check on the product to make sure you have the right product in hand before you start your infusions. Requiring independent double checks at the bedside of all epidural medication, as well as other IV medications and infusions, including PCAs, any opiate infusions, antibiotics, even oxytocin, magnesium drips is very essential to mitigating administration errors through the wrong route. Reducing interruptions has also gone a long way. Establishing a quiet environment in the patient's room. Epidural insertion should be a very separate and dedicated process. And the infusion should be started immediately as soon as the epidural is placed. So as soon as the epidural is placed, connecting the proper tubing, hanging the right bag, and starting the infusion on the pump. Conducting a thorough and correct timeout procedure is also been found to be essential to the process. Reading out loud the drug name, the concentration, confirming expiration date, beyond use dating, prior to any timeout, even in any transferring of possession of the products from nursing to anesthesia, if that's a workflow that occurs at your institution. And as a utmost fundamental, tracing your lines is very important as well. When we look at line tracing, it's really important to highlight tubing and smart pump safety. In 2006, the Joint Commission issued a Sentinel event alert addressing issues of tubing misconnections, which had become a persistent and potentially deadly occurrence that they had identified the prior years. As you know, in the labor and delivery setting, multiple administration tubes, infusion pumps, and monitoring systems are used routinely in the care of the woman. The mother can have multiple lines, but then there's also a lot of monitors for the baby or babies, depending if she's pregnant with more than one neonate. So some essential recommendations are always tracing the tubing and making sure the catheter from the point of the patient all the way to the origin into any device is thoroughly traced and labeled. Labeling any high-risk catheters is essential and fundamental for the safety mitigation of administration for the patients. Using distinctly different pumps for epidural applications. So some institutions have decided that epidural pumps will have a different type of tube, a pump, with a different faceplate. I'll show you some examples in the upcoming slides. And also using non-Luer connectors that are not compatible with IV devices, such as NR-FIT connectors. On this slide, you'll see there's a few examples of how the yellow striped tubing can look very different and it's smaller, and also implementing the use of like high alert epidural stickers for line tracing and making sure that you put the piece of tape and the labels all along the lines. And again, tracing from the patient all the way to the device is essential as well. These are some different kinds of approaches for medication administration, smart pump devices. So having a dedicated epidural pump, a lot of service lines from different companies have come up with yellow plates, or you can buy it, or you can buy it at like a piece that goes on top of the pump, having yellow. And then sometimes even the screen will change yellow. When you can't afford to buy the yellow plate, you can have a screen color change to make it yellow, and it allows it. Other institutions can even purchase yellow lock boxes. So if you are using a CAD cassette or having like a pump that's spiking the bag and hanging in the back, just having also a yellow lockbox can also go a long way too, to making sure it's differentiated. Some nursing magazines have also published some additional safety strategies that I thought were very nice to highlight, such as positioning the epidural pump on the opposite side of the bed from the intravenous pumps and medications. So working with your nursing teams and establishing the epidural will be on the right side of the bed and all the other medications will be on the left side of the bed. Simple things like that can really go a long way, because then that would also prevent lines getting mixed up from different areas on the patient room. making sure that the room is well lit whenever medication administration is occurring. I know we are all on this venture to making sure that the patient is comfortable and they're in a quiet, peaceful environment during their deliveries, but making sure you have enough lighting during the administration part, making sure the medication is visible, scanned, and really reading the label of anything you're removing off the pole prior to hanging another medication is really valuable to the proper safety of the patient. And of course, ensuring that the medication tubing is infusing on a smart pump. So taking it a step further, one of the things that has been found in the more recent literature, and that's why the ISMP published their update in 2018, is that in the event that there is an error of an incorrect route that is administered to the patient, having an established lipid rescue treatment protocol has been shown over the years to actually be life-saving. So if you'll see on this timeline provided by ISMP and published in the 2018 update, you'll see that fatalities were very consistent in all these error mistakes. So in 2000, 2001 in the UK, fatalities reported. Furthermore, in 2004, 3. 1 patient survived in 2004, 3 survived in 2005. And when the first publications of lipid rescue in humans started to be published, you'll see that the survival rate has increased for any misconnection errors that have occurred. So one of the important things is have your lipid rescue protocols established, having these medications readily available whenever an epidural infusion is being used, and early identification is key. So getting and partnering with your nursing team, your anesthesia team on how to identify quickly any toxicities from epidural infusions can really impact the survival rate of the patient in the event that a misconnection does occur. So one of the things, this is what we had established at our facility, is we created a lipid rescue treatment, like a dosing card that's available in the epidural anesthesia carts. And it's also available for the nurses that they can, read it. We have the tubing that we use, the non-DHP tubing, 1.2 micron inline filter, readily available, attached together with the dosing card in a quick access area. We have multiple epidural carts around the unit. So this really helps make sure that in the event of an emergency, they have quick access to life-saving therapies readily available, and they have dosing and administration guidance quick. And lastly, educate and communicate. So while education may have the lowest value of impact for mitigation strategies, it actually, and it has low leverage, it actually has been found that if you know how to educate your patients, you have safety strategies in place, it can go a long way. So educating your staff on the risk of mix-ups between epidural anesthesia and other IV infusions. I always say that shared learning is the best learning. The more we share about our mistakes, we learn from everyone else's mistakes. Developing competencies to ensure that practitioners are well aware of safe handling practices and epidural infusions, especially in your facilities when you have those new interns coming in, new residents. It's very important that the competencies are well developed and that they're aware of safe practices before they start working in the areas. Ensuring staff is able to recognize and manage signs of toxicity using established protocols has been shown to improve survival rates, and communicating with all practitioners of any and all changes to appearance, labeling, container sizes, concentrations, products, or directions for administration, including drug shortages, before dispensing any alternative products in your area. So to come back to the case study, some contributing factors and risk points that were identified from the event that occurred with the 60-year-old female that passed away is that the bags were both in 100 mLs, and due to shortages of the 50 ml sizes, they had changed their bag size volumes. So they did look very similar. Also create additional, the providers had met with nursing prior and established the need to have urgency and expedited cases and having everything ready to go before they started. So a lot of times the nurses, out of pressure, were trying to be efficient with their time, and they were bringing multiple products. They brought the PharmD and they brought the epidural to the patient room at the same time, and they were side by side on the countertop. Instituting procedural procedures to ensure safe environments are established. So retrieval of medications prior to the unit. So it's very important, like just grab the epidural when it's time to put the epidural into the patient. Don't grab it in anticipation or in advance unless it's necessary, so you don't have unneeded products in the immediate space of the patient care area. It's important to ensure that you do not bypass any proper pharmacy checks or ordering procedures that may need. Implementing BCMA is important and it can actually have a lot of value. Having an independent double check and ensuring proper timeout of procedures is occurring in your process. So knowledge check. Which of the following, as suggested by SMP, is a mitigation strategy for prevention of wrong route epidural errors? Differentiate epidural infusions by using a different size bag or shape. Affix large labels on both sides of the infusion bags stating for epidural use only. Fully implement BCMA. Require the infusion tubings to be yellow striped with near axial connections such as UNR-FIT. Establishing lipid rescue protocols in the event of inadvertent wrong route infusion errors, and all of the above. Yay, everyone got all of the above. So thank you so much, everybody, for joining us this evening on our road of correcting mishaps for wrong routes. So as you've learned by now, wrong route errors are potentially fatal, making safeguards essential for patient safety. Performing adequate reviews of current processes help to evaluate for risk and implementation of mitigation strategies, and staying informed with reports from external organizations assists with proactive assessments. Thank you very much. These are our references, and we will entertain any questions that you may have.
Great presentation, Michelle and Sonia and Shivana. Everyone, we thank you for joining us tonight. And I know there probably will be some questions coming through the chat, or if anyone would like to unmute themselves, you're welcome to. And I'm also going to post the process for the continuing education in the chat if you're able to see it. Just so you can have access to that. But the link will be active until August 16th, so make sure to claim your CE there. Oh, Michelle got it up too. Great. You know, make sure you remember our licenses are due to be renewed very soon. So make sure you collect your CE. But if there's any questions, please feel free to put them in the chat or unmute yourself. And there's a lot of great information in there. I hope you can take something back to your hospital.
Thank you, everyone. Have a good evening.
Oh, there's no CE code, Sandra, by the way. There was a question in the chat there about CE code. There's not. Will you offer a second hour? Oh, that's nice. You guys did so great.
But
Sounds
for
like
the
an encore.
next year.
Yeah. Oh, here's a question. Can you see the chat, Michelle, or?
Yes.
Okay.
This is, how do you balance patient safety and clinician convenience when it comes to configuring an ADS override med list? That's a good question. I know Shivana, you're more closely working on an ADS override med
Sure,
list.
yeah,
What are your challenges with that?
So in our organization, we are looking at a standardized override list so that all of the hospitals will have the same list. Part of that process of coming up with that list includes really working with a lot of other other disciplines besides pharmacy. So we do work closely with nursing leaders as well as anesthesia leaders, really to evaluate if there is a true need to override something, if it could cause patient harm, if it was not available on override, versus just wanting to have it quickly. And then part of that is really trying to build trust in the pharmacy's ability to also, have a timely review of orders to prevent delays, and which is what sometimes heightens the requests to have things on override. So also looking back at, what can we do within the pharmacy to ensure that we can have a timely review to make sure those meds are available without having to be overridden. So it takes a lot of really working in collaboration with other leaders.
One of the things I'd like to add is we stress a lot that the use of the override button is a high risk function in and of itself. It opens the door for liabilities. So we stress the importance of, is it critically necessary? As in, is it life-saving for the patient? Because a lot of times we'll get requests for medications that may not be as critical in need or life-saving in an urgent situation. So stressing that, well, is that a life-saving medication that you need it critically? And when you put it in those words, they realize that they have to wait for pharmacy to verify the order, because a lot of times they're very accustomed to having access to medication. So it's a journey, I would say, especially even as fundamentally as flipping your automated dispensing cabinets to profile settings from non-profile settings. So there's many layers, like they said already in the chat, in the process. But really also it actually improves with BCMA too. We've told them that, it's gonna help you when you have the profile settings, you're gonna pick the right medication. When you go to the bedside, it'll be easier to scan. And also using override, you're gonna have to probably go back because you picked the wrong medication, it won't scan. So a lot of opportunities, and really selling it to your disciplines as really the best safety strategy that they can have. I also tell them it protects the nurses too. We've learned a lot from other cases that have come out with the neuromuscular blockers, that just the usage of that little override button just opens the door for liability. So we say it protects you. So really when you go to the override function, and typically in the acute care settings, there's already a crash cart that has really most of those medications readily available as well. I agree, there's a lot of improvement in the space available.
Yeah.
Yeah, there's a comment in the chat. The pharmacy has big problems with drug shortages, which requires the pharmacy and nursing staff to maintain a good communication. And I think that definitely is, it resonates with all of us. We have a very proactive anesthesia team and nursing team. And whenever there's a drug shortage, it's very important to highlight them, especially for epidural safety. I know Shivana can speak further about, we do have like a system-wide drug shortage committee, as well as local entity drug shortages that get, a lot of information gets blitzed to physicians, nurses, and leaders across the system routinely for shortage awareness too.
There's just a question there about expecting the email link in your mailbox soon. I believe it usually comes, let's see. So she said to contact Tamika if you do not receive the link to the evaluation within 24 hours after the webinar. So it should be sometime tomorrow. And if you don't get it, please contact Tamika. But great discussions here. Oh, Tamika just said it takes about 20 minutes for Zoom to send me the attendance. So yeah, should be sometime tonight or early tomorrow. Any other questions? Once again, I think this could go on for a second hour. It sounds like they want an encore. So maybe next year we'll have another great one. All right. Well, thank you, everyone. Hope you have a great night.
Thank you. Have a great night.
Thank you.